We need to assess on the slit lamp if there's any phacogenesis, possibly performing UBM, OCT, seeing the configuration of the tear segment, and checking for any zonulodialysis. Of course, now the pupil is in a fully dilated situation. What is the status of the pupil? Is the pupil reactive to light, or is there a traumatic mydriasis? What type of injury did the patient have? Was it a ruptured globe or a perforating, lacerating injury? Was there a foreign body? So this all needs to be assessed preoperatively. Accordingly, one should then prepare himself for the tools that might be needed. If there's if there's phacogenesis, one needs to assess how many clock hours of phacogenesis. Will I put a CTR or a modified CTR, or shall I need a capsular retention segment? All this needs to be kept in mind. Axial length is very important because the size of the CTR depends on the axial length. If it's less than 24, if it's between 24 and 28, if the axial length is above 28 millimeters. So all this needs to be taken into consideration. So maybe you can answer many of these queries that I've put forward. What is the state of the pupil? What is the status of the iris? Is there any lost iris tissue? Is the pupil nice and round? Is there any fixed dilated pupil? Is there a foreign body, or was there no foreign body? Was it just a stab injury, and then this cataract developed months later? So maybe you can possibly answer.
Yes. So that's fine. That's a very good approach, and we expect such approach. But the point is, I ask this question because this is very importantly, like, yeah, alhamdulillah, in some hospitals, like in Kekish, we most of the facilities is available, or are available. So sometimes you can after you assess the case, you can go ahead and go for surgery because you know what you have in your OR. But in other places, you really need to prepare yourself, as Dr. Barry mentioned, from assessment point of view and from instrumentation points of view. Because if you enter inside the eye and you don't have these instruments and instrumentations, you will be in trouble. And if you don't expect what the complication you might face, then again you will be in trouble. So this patient has a penetrating globe injury, and as you can see, can you see my mic?
Yeah, we can see it.
Okay,
we can see the mark.
Great. So it was corneoscleral incision, corneoscleral wound here, and the patient had primary repair done nicely. The vision was fine, was almost 20/60, 20/40, something like this, until like 4 months or 5 months ago, before he presented to us. As you can see here, this area, you can see these notches. So these notches will present the ciliary processes, which indicate that there is no iris, there is total iris loss during the surgery, during the trauma. And as you can see here, you can see that the lens itself is displaced or subluxated toward the wound, although the vision was good. And from the zonal point of view, all the area here, the zonules are intact. Although it is stretched, but intact. There is no vitreous loss. And it was very nicely when I stained the capsule, the anterior capsule, it stained the zonules in a very nice way. Maybe I can just proceed with
this. This is a case of traumatic aniridia and cataract, which is intumescent and slightly subluxated.
I just want to stop at this slide and ask Dr. Abdallah Asiri. Dr. Abdallah, you can see here that the lens, first of all, the cause of the drop of vision is the sudden intumescence of the cataract. The cataract at a sudden became, although for more than almost a year, although you can see here that the capsule, after I stain it with the Trepan blue, the capsule is open here. And this is not a child. He's 30 years old. So Dr. Abdallah, when you have a patient with with penetrating globe injury, and you have the lens, the anterior capsule is breached, like in this case, are you going to do the cataract at the same sitting, or you just close the cornea and the sclera if it is open?
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Saad, and for the Saudi Ophthalmology Society for starting this webinar, which is, inshallah, it will be interactive, and it's something that we face, you know, in the clinics and also in the emergency room. Actually, when I saw the case in the beginning, I didn't realize the red reflex. I thought this is an iris. Then when you told me this is iris processes, I realized this is a red reflex. So now the you know, the picture is more clear to me. As in this picture, I can see that the capsule is wrinkled. So most likely, you know, the trauma is involved the lens, and it's a bit strange that it took this time, that it did not become mature. And definitely, you know, at this stage, doing capsulorhexis or capsulotomy, it will be a bit difficult, because I would expect the anterior capsule will be, since it's wrinkled, it will be fibrosed, and sometimes it will be difficult to do rhexis in this case. Sometime you can use what we call it dithermic capsulotomy in some cases. You know, maybe this case you can manage in the beginning, but probably at this part of the capsule, I think it might give you some difficulty. You might have an extension when you do it. You mentioned that the zonules is still attached, which is a good sign that there might be some, you know, good zonular, you know, support of the whole capsular bag. But sometime when you enter the eye, when you enter doing the surgery, you might find something different. So as mentioned in the beginning, you have to be prepared for all the possibilities, because trauma, even, you know, preoperative assessment, even when you go to the surgery, you might find something different. So doing the capsulorhexis, capsulotomy, dealing with this lens, during the surgery, there are things that, you know, can change, you know, your plan intraoperatively.
Yeah, back to the question, to our question, during the acute stage, although it's not our part today, but
yeah, okay, yeah.
If the lens is, the anterior capsule is breached, like in this case, are you going to the cataract surgery?
I would not, no. I would just do the primary repair, and unless there are some cortical material, which is, I can see it in the anterior chamber, then at this stage, I might consider, you know, probably this is a young patient, I might do some sort of lens aspiration. But if you know, and at this case, if I can see the lens, the capsule is injured, I would not, you know, proceed to do the lens or to do the cataract, or to do, you know, lens aspiration at this stage, because you know, my aim is to do the closure of the eye. I don't want to have an infection which might spread posteriorly and give this patient an endophthalmitis.
Okay, great. So so does this matter if the patient is young or old, Dr. Abdullah, for the cataract extension?
I think if he's young, it might be easy, because the lens material is easy to aspirate. If the capsule is widely opened, and you can see some you know, cortical material in the anterior chamber. But if this patient is old, you might have, you know, heavy lens, and then you have to do, I mean, a harder lens, and then you have to make an opening to deliver the lens. But in a young patient, definitely it will be soft, and probably while, you know, cleaning the eye, there might be some lens material that you can aspirate it at the same time.
Great. Thank you, Dr. Abdullah. Dr. Ali, for such intumescent cataract, Dr. Ali معانا?
Yes.
Great. So this is not too intumescent, although there is some intumescent in this type of cataract. But the difficulty in this lens for the capsulorhexis is the area of the opening in the capsule, the area of the wrinkling, and as well the area of the zonular dialysis here. How would you approach the capsulorhexis in these cases from the point of the staining to the point doing the capsulorhexis, how to approach such capsulorhexis in such cases.
You know, as mentioned by Dr. Asiri, one way of doing it is diathermy, another is by femto, and a third thing also, which I have tried in young individuals with very tense capsule and zonular dialysis, is using a straight 30 gauge needle. Rather than having it puncturing it is on vertically, anterior posterior, you can do it tangentially. And then with the 30 gauge needle, you can easily puncture and then do capsulorhexis, which is small in the center. Another way of also doing is not, because you have an opening there in the capsule, which is peripheral, if you can just aspirate manually of this cortical material, since he is young, he can aspirate and release any tension of the anterior capsule. And then if he cannot remove all the cortex, you can fill it with viscoelastic and then do capsulotomy. So all of these options can be done with this case.
Okay, can you hear me? My voice is clear, is it?
Yes.
Okay, so what type of stain? Because we're hearing that the trypan blue will weaken the capsule in such cases. What type of stain you will use in these cases?
I'll use Vision blue, trypan blue. The green. I don't use it, but I don't find any other stains that is better than trypan.
Can you see
one comment, Dr. Saad, because I would expect this is a young patient, so I don't think the trypan blue would make it so weak. There are cases in which you have very like mature intumescent cataract in an older patient, not in a traumatic case. So this is the cases where you, as you mentioned, yeah, the trypan blue can weaken the capsule and you might have capsular extension.
Okay.
Can I add the point?
Yeah, go ahead, doctor.
Yeah, you asked in the beginning, would you intervene or would you wait? I think it's always a different situation. One needs to assess the situation. If the cortical matter is dispersed in the anterior chamber with fluffy material, inflammation, and uveitis, then one needs to intervene and perform probably a lens aspiration. But like in your case, it seems that although there was a defect, the lens matter was contained. It's always better to wait and perform it as an elective surgery if there's no significant ocular inflammation. Everything becomes more predictable in cases from keratometry, and the surgery becomes more comfortable visualization. The anatomy of the eye is being restored. So it's a very different situation when operating on an elective procedure versus an emergency procedure. So I think it was the correct choice that you took, since there was not significant inflammation. The second point, the wrinkling that I can see on the capsule, this might signify that there is some sort of zonular weakness. But I see you were able to.
Or it is from the trauma itself, doctor, at this area.
Unless it's a fibrosed, type of wrinkling. So it might be a fibrosed type, not a sign of.
There was fibrosis at this area, and as you can see, I just go with the capsulorhexis. I just try to spread the fibrosis from the area of the capsule. And even though I couldn't do it, then I used the microscissor, the curved microscissor, to continue the capsulorhexis. Although, as Dr. Rajhi mentioned, you can use the diathermy to complete it, but I found it very difficult. Maybe you saw during the capsulorhexis, the capsule at this area was very fragile. It's keep cutting from me. But when I went to the other side, it moves smoothly. But when I reach again to the same area of these wrinkles, it keep cutting. So I continue doing it with the curved anterior segment scissor, which helped doing it. My question is back to Dr. Abdullah Asiri. Doing the cataract, the phacoemulsification in such capsulorhexis, where you can see the capsulorhexis is not very regular. So how you can do the phacoemulsification without enlarging any extension in the anterior capsule?
Probably you might, in this case, I think I would assume the lens is not that, hard. So it's easy it will be aspirated easily. Maybe you don't need to do a lot of hydrodissection, maybe very gentle hydrodissection, so you avoid any possibility of extension, or some of the, fluid might go posteriorly, and this might increase if there is a defect in the posterior capsule, you might increase or made some vitreous hydration, and this will give you little bit AC, make the anterior chamber a bit shallow. I think it would be easily aspirated, and as I can see in the video, maybe you didn't take much of time here, but as I said, avoiding very aggressive hydrodissection, this is an important thing. Maybe very gentle. Sometimes you don't need to do it in such case, because I would assume the lens is not that hard. It is a soft. It's like more or less like a lens aspiration.
Yeah, exactly. So when you have such a trauma, you don't know what's sequel of such trauma to the posterior capsule. So I just repeat what Dr. Abdullah said regarding the hydrodissection. Just if you are if you either try to avoid it, or if you want to do it just gently and slowly, just to make sure that there is no opening in the posterior capsule. As well, we might consider doing such cases very soft, but in such if the cataract is hard, then you might do it, you might pop it, or you might just try to crack it in small or segment it in small pieces. Then try to as minimal manipulation inside the bag as possible. You can do it as well like supracapsular, the cataract, the phacoemulsification, just in a way to avoid any extension of the anterior capsule, which is not regular, as well to avoid any drop of the lens if there is opening in the posterior capsule. Dr. Ali, how would you manage such an iridia case?
Before an iridia, because the anterior capsule opening is at the periphery, and you don't know if the posterior capsule is intact or not, one way of doing it, as you mentioned, is popping the nucleus into the anterior chamber, anterior to the anterior capsule, and then do phacoemulsifying it. This, as you correctly mentioned, it will prevent any tension on the posterior capsule and extending any rupture, if there's any, as well as to have all the fragments more approachable to be phacoemulsified. Regarding zonular dialysis, this is tricky because of this opening in the anterior capsule. But I would, if there is zonular dialysis, I would go ahead and do a smaller capsular tension ring, which is 10-12, into this side. And you might start in the area a little bit away from this area of capsular opening, so that when the end, it will reach that area, rather than going somewhere else, and then you suddenly find that your end of anterior capsular tension ring popping into the anterior chamber or so, because you don't know exactly if that opening is extending to the zonular zone.
Can I add one point? Can I add one point, please?
Yes, just if you would comment also, Dr. Ma'an, on the CTR, the risk of CTR in this case.
No, I wanted to also, before that, to comment on the fluidics. Using the regular or high fluidics, this might cause irrigation misdirection, and make a complicated case even more complicated. And I think maybe most of us have seen such cases, especially in previously traumatized eyes where there's compromisation of the zonular complex. I think what Dr. Ali has mentioned is very wise, is to start just probably adjacent to the area of the zonular trauma, facing a capsular tension ring, and then ending up from the other side of the trauma so that that area is not disturbed. I think the behavior of the contracture, this lens capsule was very much distended from the intumescent cataract. The behavior after the surgery, the contracture of the capsule is not going to be your regular contracture, symmetrical contracture that usually happens in the virgin eye. So placing a CTR might help in this situation, and possibly even placing a 3-piece IOL.
One more thing, Dr. Saad. You know, Brian Little has his own maneuver in inserting the capsular tension ring. Rather than inserting it through an injector, you can insert it in a fish mouth technique, where it will reduce the zonular distress, and you can always have better control of the two ends of the capsular tension ring. Another way also of doing that has been also being reported is, rather than having this capsular tension ring goes to the vitreous cavity, is to have the leading eyelet as a suture, so we can always pull it if it goes to the vitreous.
Yeah, that's great. So just can you go back on the aniridia choice, Dr. Ali?
For the aniridia, I mean, you can use in the capsule or in the anterior chamber. As you know, there are companies that make and match iris processes and doing iris prosthesis, and you can send it to them, do for the other eye if you have total aniridia, or use the same iris, and then you can fashion this iris and cut it and insert it into the iris. There are two ways, like Dr. Smith company. You can have two types of iris prosthesis. One is with a mesh that you can suture it to the iris. Another one, you can just place it if you have total aniridia, and this can be folded and it's refined and everything. Another way, as you mentioned here, is to have two rings which are silicone and they are black in color. The problem with these, they are fragile, so they have to be inserted very, very careful, and they have to be in the capsular bag. And you can have, you are inserting one, but you can also put another one, so these are opening. I prefer the other one is better because it is easy and non-fragile, and you can always adjust it to the size of the eye itself, but it is more expensive.
Yeah, so that one is the one. It's the only now FDA approved one from. It was in Schmidt, I believe, from Germany, and now it is for human optics now in the US. That one you need. Actually, I was planning to do it for this patient, but all of a sudden this patient came to me in the next visit with really intermittent cataract, and I don't want to wait more. Then I have these rings in the hospital. I just go through do it, because that one you need to take photos from the other eye to match the color of the iris. Since we don't have any iris in this eye, then you need to send it as a hard copy to the company to have it. They will not accept any emails or something like this to avoid the exposure, overexposure from the computer. I think my time is over. It just if I can take just a choice of IOL from Dr. Asiri, with a single.
Yes, sure. Thank you, Saad. I think in this case, since you mentioned the aniridia solution, Since I have the back, this patient is lucky. I would avoid anything in the angle or in the anterior chamber, because as mentioned by Dr. Ali, is the iris prosthesis. There are some reported cases of some uveitis or iritis, sorry, after these cases. The one that you implanted, sometime you have difficulty because you need to rotate it in a way that it will be at the end it will show like a one segment. Sometimes it's a bit difficult and to put it. And the other thing, whether to put the lens before or before the tinted capsular tension ring or after, because sometimes if you put the CTR, you might have difficulty to put the lens. In this case, you know, it's both. It depends, you know, if you want to put the. Personally, I might put the single piece, because putting the three-piece lens, I might have difficulty, or I might do a lot of manipulation, which might compromise my zonules. So it doesn't matter, you know, if you put the single piece or the three-piece, since you put this two tinted CTR ring. But as I said, you might have some difficulty when you rotate these two segments to cover the you know, to be overlap. But I think you did a great job in this case.
Yeah. So just to echo the for the rings, the iris ring, it's a Morsher type 50C, that the one I used. There is many other things. I like this one because it can be inserted through the same fake wound. The other, you need to enlarge the wound to about 3 or even larger than 3 millimeter, as well as this has the pupil is a little bit large. This has some over like the one patients sometimes they don't like it because the pupil is large. The pupil, I believe it's 6 millimeter, the one I used. There is other up to 3 millimeter. So again, it depends on the need of the patients. It depends. Like if the patient is diabetic, then it's better to use the one with larger pupil, and you might use the one with smaller pupil, but you will have really difficulty to insert. I used it. It's really difficult. It has some difficulty, to be honest, and you need to enlarge the wound, and it is fragile to some point that it might break. So you need to have always a spare part to use in case these rings is broken. And as Dr. Abdullah mentioned, it's advisable even by the company, and I found it easier to insert first the ring, then insert the other ring under the first one, then insert the IOL under both rings. This will be easier. I believe we'll go to Muhammad. We'll go to the questions.
Yes. Yeah, please. Let's have. I think we have mainly 2 questions. One of them is, what about femtosecond laser to perform?
Dr. Ali Rajhi, I think you touched this point.
Certainly, it's an option by doing femtosecond for this case. I mean, doing capsulotomy will be much circular, and it will be very regular and circular and central. So this is an option.
Dr. Barry, do you think the Vision Blue, if it's used in these cases, it can go to the fundus? Any harm from this, Dr. Barry?
Yeah, of course. If it goes to fundus, it will just make the procedure more difficult. You will lose the lid reflex, and the procedure will become very more challenging. So it should be. I would advise maybe to use start with a dispersive viscoelastic at the periphery at least, and then very gently stain the anterior capsule, so that to avoid any trickling of the Vision Blue behind the capsule, and then filling the vitreous cavity, which can become a problem.
Dr. Saad, was there any, because
what about using yes, go ahead.
I mean, I can see the wound on the limbus, which I would assume there will be a high stigmatism for this patient. Did you tackle it before that, and then you think what you can do for it?
I can't remember actually now. What is the topography of this patient, and what is the astigmatism of this patient?
But one of the preoperative measures is to do topography before, since he has peripheral corneal scar.
I think it was done, but I cannot remember the case. So again, Dr. Asiri, as you saw in the area of the wrinkling, do you think using the cutter, vitreous cutter or the occitome at that area is of benefit, or it might make the case more difficult?
Cutter for what? For
vitreous cutter to cut the capsule, the anterior capsule.
I wouldn't, you know, if even sometime I would cut it with scissor, because as I said, you know, I may not consider doing, you know, hydrodissection at this case. So I will not be afraid of having, you know, radial extension. So I will just do if I have difficulty, sometimes you have some fibrosis at that area, you will have difficulty to complete your rixus. So sometimes you just snip it with the scissor and then you complete it, rather than go with the cutter.
Last question to Dr. Berry. One of the attendee asking, can an iridia CTR be inserted in the bag if there is extension in the anterior capsule? As well, yeah, the conventional CTR, can you use it if there is a extension in the anterior capsule or small BCR? Let's make it more wide.
No, I don't advise. You will just it might just run away and cause problems. I think it's a contraindication.
Yes.
Okay, great. I think by this I conclude my part, and thank you all for participation, and we'll enjoy Dr. Mhanna Al-Jandain talk, inshallah. Mhanna, are you with us?
Thank you, Dr. Saad. It's a nice case.
Barakallah feek. Thank you.
Stop sharing, Allah khalik.
Mhanna?
Stop sharing, please.
Sure.
Assalamu alaikum, bismillah ar-Rahman ar-Rahim. First, I would like to all in this webinar, and also I would like to thank the SOS for organizing this webinar and also for the invitation. So now I'll just share my slides. So is it clear, or the video?
Clear, yes.
Did you open it? No.
Your screen is clear.
The video.
There's no video.
No, you did not run it yet.
نفس اللي صار لنا اليوم. Okay. Is it now? Still no?
No, we can see suture CTR only.
Yeah, I بشغلها.
Share the screen maybe.
Yeah, I'm sharing the screen.
لا، شير الديسكتوب كله احسن. طلع الفضايح.
Yeah. Okay.
Now it's okay?
Yes. But
Okay,
the video,
now
okay,
it's
yeah.
okay. Yes, yes.
So I've received this patient. He's a 40-year-old gentleman who had a trauma by a tennis ball into his eye. He came to me like 4 to 6 months post-trauma, complaining of monocular diplopia and decrease in vision. While examining the patient, I noticed that this patient having a subluxated cataractus lens with more than 200 degrees of zonular weakness or absence. So I would start my video and we'll go through the approach that I use in this case. First, I did a 2.4 millimeter clear corneal incision in the temporal side. After that, I injected a viscoelastic, a cohesive viscoelastic at the side of the crystalline lens, and also I used a dispersive at the area of the weak zonules. After that, as you can see, the lens is not only subluxated, it's also tilted into the vitreous. So by the aid of scleral indentation, I created a puncture using a cystotome. Then I initiated my capsulorhexis. And as you can see, it was very difficult to do the capsulorhexis, and that's why I stopped and created a few paracenteses at the area of weak zonule. And due to the severe tilt of the lens, I elevated the lens using the viscoelastic cannula and then holded the lens using an iris hooks. So this is the first iris hook, and then I used another iris hook. I'd disappear and ask the panelist would you in this case use an iris hooks or capsular hooks, and why? Dr. Ali?
You can use capsular iris hooks if you don't have capsular hooks. The advantage of capsular hooks is the tension will be on the equator of the lens rather than anterior capsule. And it's not available everywhere. So if you manage with this without any tension on the anterior capsule and without any extension to the capsulotomy, this is fine. Another way also of doing it is, as you start correctly with this, is to insert capsular tension segment and then insert it there and then pull the lens towards the area of the zonular dialysis. And you can remove these hooks so that the tension will be on the equator of the lens, and they can proceed.
Yeah, definitely. So what I did here, I just put the iris hooks, and after stabilizing the anterior capsule, no much tension is applied into the iris hook. I injected a cohesive viscoelastic and then completed my capsulorhexis. So as you can see here, when I completed my capsulorhexis at the area of the intact zonule, the capsulorhexis direction was easily manipulated and obeying my command. And as soon as I reach the area of the weak zonule, you notice that I'm starting to lose the direction or the desired direction of the capsulorhexis, and it went to the periphery. So I saved the capsulorhexis by pulling into the opposite direction and then completing a continuous curvilinear capsulorhexis. Having a continuous curvilinear capsulorhexis is very important in these cases. If you fail, you cannot fixate the bag using the CTS. So after completing my capsulorhexis, I also added more iris hooks to fixate the bag. And I would stop here and ask, would you, for the panelists, insert the CTS now, or if you felt that the bag is stable, would you keep it till the end, Dr. Asiri?
When I see the lens, you know, there is a lot of manipulation. It means even the other part of the lens, the zonules is not even you know, it doesn't have the enough strength. So it's a bit even risky, you know, when you manipulate this case. I would, you know, it depends on the density of the lens. You know, if it is like a soft lens, I might just consider, you know, like, you know, doing hydrodissection, deliver it a bit anteriorly, and then, you know, aspirate it gently. The problem, if it is what they call it, if it is so dense, or if the lens is a bit hard, I might consume a lot of energy, a lot of stress on the zonules. I might consider putting one CTR and try to put it gently, because you have very large, you know, what they call it, zonular dialysis.
Yeah, so that's what I thought of, and because of this lens is a medium to soft density, so I've elected to just complete my phaco. And here, as you can see, I'm doing stop and chop. Despite doing phaco chop would have better or less stress on the zonule, my hand stop and chop, gentle stop and chop can do the job. So after cracking the lens into two hemispheres, I've tried here, as you can see, to pull gently on the one of the hemisphere and produce it into the anterior chamber. And due to the movement and the severe weak zonule, it was a little bit risky. So I've stopped, exit the anterior, the eye. But before we exit, we should know that to inject viscoelastic. And then I did the viscodissection. So viscodissection helped me a lot, separating the lens nucleus and cortex from the compromised capsule and bag, made the manipulation inside the bag much easier. And here, if you can see, also the rotation of the lens was less traumatic after the viscodilatation. And now I can manipulate the lens from the bag into the anterior chamber, away from the area of the weak zonule. After I manipulated the lens into the anterior chamber, I started eating the lens using the phaco. I'm using a very low parameters. I'm reducing my irrigation, protecting the bag from getting into the phaco handpiece by putting the second instrument between the phaco and the capsule. And then, as we know, before exiting, you should inject viscoelastic not to collapse the anterior chamber and prolapse the vitreous into the anterior part of the eye. Inflate the anterior and the bag, and here I saw that there is more area of weak zonule, so I added more iris hooks. And at that time, I decided the area of the capsular tension segment, so I did my conjunctiva periotomy at the site of maximum weakness. Then I've injected more viscoelastic to inflate the bag, and here, as you can see, I start injecting the CTR. I will stop and ask Dr. Ma'an, CTR, the sizing of the CTR and the area of injecting the CTR in the case of weak or compromised zonule. Any recommendation?
If you allow me to comment, I would have, going back to when you were doing the capsular rhexis, I would have used the iris hooks on the opposing vector force. That might have helped in not causing or lessening the chances of a running suture. I would have also used the capsular tension ring and possibly a segment from the beginning. This will prevent collapse of the capsule during different steps of the procedure, especially as you remove the lens matter. If there's no support, because there's a significant zonular weakness, the CTR will prevent collapse of the capsule. So I would have placed the capsular tension ring from the beginning, and possibly, as Dr. Ali has mentioned, placing a capsular tension segment as well, having the force or support from the equator of the lens back complex. I would start, of course, from the area just adjacent to the weak area, and then ending up at the weak area, so that I don't cause further damage. But mashallah, you managed to bypass these possible complications by using viscoelastic. So using viscoelastic, dispersive and cohesive throughout the procedure is very important during this procedure, as you mentioned. And using low fluidics is very also important to prevent also irrigation misdirection. But you might have less relied on using a lot of viscoelastic had you used the capsular tension ring and segments from the beginning.
And really, the sizing of the CTR?
The size of the CTR, as I mentioned earlier in the previous case of Dr. Saad, depends on the size of the eye, the axial length. If it's below 24 millimeters, if it's between 24 and 28, above 28, you can use 12, 13, or 14 in regards to the size of the ring. This particular case, I think, will need both a ring and a segment, because there is more than 120 degrees of zonular dialysis. So this needs support, and I would probably place a segment in both sides.
Okay, and would you place a segment of the CTR first?
Sorry?
Would you place the segment first or the CTR first?
CTR, capsular tension ring first, and then a segment, or vice versa. But had you I would have done this from the beginning, not towards the end.
Excellent. Okay, so yeah, anything more?
I have a comment. Yes. I think Ma'an correctly mentioned that I would have used capsular tension segment from the beginning. First of all, having one case successful doesn't mean that all cases will be successful. So we should have probably way of managing things, not for only one case, but for cases to come. And it's always better to be more cautious and to have the capsule, the complex is well stabilized before you proceed with phacoemulsification and cortical material removal. And with this degree of subluxation of the lens and having these hooks holding the lens during phacoemulsification, in one case is successful, but doesn't mean that all cases will be successful. So as probably more cautious to have the capsular tension segment first, fixing the capsule bag at one area that have mostly zonules. You can even have more than one capsule tension segment, two areas, and then having the CTR. The sizing is, in all my experience since 2001, it's very rare that you use large ones for large globes. I mean, they come in three sizes, but they usually 10 to 12 or 11 to 13. And another way of doing it is using CNE type capsule tension ring that has one or two eyelets. But this also is more difficult to insert. So capsule tension segment, and then followed by capsule tension ring.
Excellent. So what I did here, I injected my capsule tension ring and making sure that capsule tension is in the bag. And then I've noticed that I have vitreous coming from the main wound. So I did a limited anterior vitrectomy. I created a paracentesis to pull the vitreous away from the wound. And while waiting for the vitrectomy to be ready, I just tested my capsule tension segment that I'm going to implant it, as Dr. Ma'an and Dr. Ali mentioned. And I elected to do a dry vitrectomy just to remove the area of the vitreous strand. I did not want to do or insert with an irrigation, not to invite more vitreous into the anterior part of the eye. Any comment, Dr. Abdullah, regarding the vitrectomy at that time?
Yeah, I think it's good. Probably, you know, I would try to, you know, to stain the vitreous so you can see if there is any strands or any more strands. But I would do, you know, the, you know, limited vitrectomy, make sure there is no vitreous going to the wound, and you know, rather than if you just keep manipulating, you might induce later, you know, retinal detachment or you know, later complications. So I think what you did is fine. Maybe you can stain it, and then you can just you might see some, you know, hidden vitreous that you cannot see it easily.
So after doing the vitrectomy, I prepared my CTS. Here I used 10O proline. I entered through the central coma-like eyelet, and then introduced the capsule tension segment into the anterior chamber, and then manipulate it. So I would have the diaphragm of the capsule tension segment to be inside the bag, and the central coma-shaped eyelet in front of the anterior capsule. After putting the CTS inside the bag, I removed some of my iris hooks because the stability of the capsule now is a little bit secured with these with this capsule tension segment. And then I used a cohesive viscoelastic to separate the area from the anterior capsule and the iris. And here I used an ab interno technique with a long curved needle going 2 millimeters away from the limbus. This is the leading arm, and then the trailing. Also 2 millimeters away from the limbus, and it's separated between each other is 1.5 to 2 millimeters. After that, I pulled both arms, assuring that the eyelet of the central coma-like segment is above the anterior capsule. This is very important. And after assuring that, I just sutured or tied the 10O proline, preliminary tightness, and then I would adjust it at the end of the procedure. After doing that, I went with the Simcoe. Simcoe have better control and less traumatizing to the bag complex, and removed the remnant cortex. And then I inflated the bag with a viscoelastic, removed the last iris hook, and implanted the IOL in the bag. Any comment, Dr. Ali, about the type of IOL you would use in these cases?
The same question came again. The zonules on the opposite side, since you have very big subluxation of the lens, was it intact?
It is intact.
So because it was tilted, you mentioned.
Yeah, the superior part, it was intact.
Okay. Regarding the lens, if you expect that you will suture it, A 3-piece is probably more suitable to be inserted. I have inserted 1-piece as you did. It's easy and better control to use it, and probably it's fine. You can use either 1 3-piece or 1-piece IL. The advantage of 3-piece, you can always go back and suture it to the iris or suture it to the sclera if you want to.
So here I just implanted a single piece IOL, trying to have a little manipulation and to put the IOL into the bag and centralize in the Purkinje reflex. And after securing the IOL inside the bag, I did more vitrectomy at the area of the previous vitreous prolapse. And after that, injecting a constricting agent to constrict the pupil and assuring that there is no vitreous in the area. Unfortunately, I did not have a triamcinolone in the OR at that time. It would be more helpful to stain the vitreous, as Dr. Asiri mentioned. And after that, assuring that all opening is secured with no opening. This is the photo 4 months post-op. You can see the capsule is a little bit peaked at the side of the area of the capsule tension segment.
Which area is this area?
It is inferior nasal.
Is it how it is related to the capsule tension segment? The opposite side or the same side?
Same side.
Same side. Same side?
Yes.
And the vitreous that came from zonular dialysis in that area?
The subincisional.
So you have zonular dialysis in that area, correct?
Yes, at that area here.
Did you do CTR?
Yes, I injected CTR.
Okay. Because I missed this part of the video. CTR, I didn't see it.
CTR, and after injecting the CTR, I introduced the segment. Definitely, I've tried doing the GTS before removing the cataract. It is a controversial issue. The problem, it makes the surgery a little bit more complicated. If you have, as Dr. Abdullah Asiri mentioned, a dense cataract and you are expecting to have much manipulation, I would rather put a segment before doing my phaco. This was a little bit a soft lens, so I've elected to just prolapse the lens into the anterior chamber. And I felt that it is, I'm managing the weakness without having any problem. But yes, I agree with you that putting the CTS before doing the phaco, if you think that you have a lot of manipulation or if you have more dense cataract.
I have a question, maybe for all of you. When do we consider, ignoring the capsular bag and just think of, just remove the whole thing and then you do vitrectomy and then the secondary sutured IOL? When it is safe just to keep the bag, what with the parameters? This is for every, it's a question for all of us.
If you are not confident and not competent in managing these cases, you go ahead and remove everything. If zonular dialysis is too much, the point of keeping a capsule might not be important. And I found that some of the cases like Marfan's, although they are having zonular dialysis in one or weakness in one area, the other zonules might be strong, so you can always manage them. In addition, like homocystinuria, for example, I have been always managing just with capsular tension segment rings, without any segments. They are small and microspherophakia, and this will stretch the capsular bag, and that might be adequate. And some of these cases, even you can have the lens pops anterior to the iris, but you can always control it with capsular tension rings and stretch the capsule, and patients can be followed for years without any problems. So it depends on the surgeons. It depends on how much zonular weakness or dialysis are there, and the availability of tools you have. If you have capsular tension, if you have capsular tension segments, if you have hooks for the capsule, or you don't have.
Dr. Ma'an, any comment?
Yeah, I do have a comment. I think a week or two ago, more than maybe 2 weeks ago, I attended a webinar. I was trying to find out the name of the senior Egyptian surgeon, and he mentioned that patients after more than 10 years can have significant this drop of the lens back complex. Sometimes even when these patients, he showed videos of surgeries that were done 10 years earlier, 15 years earlier, when the zonules appeared to be not so weak. Patients had like 120 degrees or more, or sometimes less of zonal dialysis. And he only placed a segment or a ring, one segment or one ring, like in Dr. Jandan's case. And then years later, the whole complex began to become very weak, and some cases where he only placed a ring, the whole complex dropped in the retina, to the vitreous cavity. So I think we do lack in the literature very long follow-ups, in 1 decade, 2 decades, of what happens, especially in these relatively young patients who are in their 20s, 30s, 40s. So that's why I commented that it might have been better to place 2 segments on both sides, on opposing sides, so that if you're doing the procedure, you want to do it once and for all, and this might probably save the eye from a future procedure. So, and in answer to your question, whether I echo what Dr. Ali Raji has said, it's better to do whatever you feel is more safe in your hands or in your facility. Sometimes it becomes more of a hassle during these fancy procedures. Maybe it's just safer if the zonules are just too compromised to do an lensectomy and then place a sclerofixated lens.
Yeah, because as you mentioned, we see some of the cases that they have pseudoexfoliation, and then we do it, and then we put CTR. Then years later, you can see the whole, they will have subluxation. So it's really, sometimes you have to, weigh things, if the zonules is enough, and depends on the age of the patient. There are many factors, I think, whether to go for, CTR, suture CTR, and then, or just you go for remove everything and just put, secondary, sutures lens, like, sclerofixated lens. We have Dr. Saad here, is not anymore here.
هل في questions للتوك حقك معنا؟
والله ما اشوف They ask about any special way of triamcinolone preparation for anterior vitrectomy. متى نسوي ICC and sclerofixated IOL? It was answered. The CTS, any risk of capsular rupture under tension? I had never had a rupture capsule while putting the CTS, but I think definitely pulling against the anterior capsule, it may cause any rupture. Dr. Ali, any comment?
What was the question? I missed it. No, I was looking for the other question.
Putting the CTS, would it have any chance of having capsular rupture under the tension of the CTS?
Well, it can, yes. It can. I mean, it is much easier and controllable compared with the CTR, because it is segment, easily inserted and easily fixed. And this is why I would always start with CTS before CTR, especially with the cases that you have, similar to the cases that you have presented.
And here's a question, Dr. Muhanna, how much time did you take in this procedure? It took more than 1.5 hours. It was the only case in the list at that day.
يزين الفيديو editing huh?
Yeah, I really think it took like 8 minutes, but actually it took more than 1 hour. And I agree. She asked if you have, أنا ما أعرف من JJ. What is this? So she asked,
one doesn't have
much cases in the list. Would you do this procedure or la? I think these type of cases, you know that you may take longer time, and you should adjust your schedule based on the type of procedure that you are having.
There is a comment. I mean, for people who are afraid, or it will take time for fixing the CT capsular tension segment, you can always replace the hook instead of the anterior capsule and attach it to the eyelet of the capsular tension segment. And this will be a temporary measure to fix the capsular bag until you suture it later. You can always remove it and put a suture.
Yeah.
And you can see videos on YouTube also having the eyelets fixed by CIF4 needle or straight needle. You go through the eyelets one hand, and then the other hand with the needle, you go outside the eyelet, and then you fix it. So this is a temporary measure. You can always have the capsular tension segment with just iris hook fixed to the eyelet.
Yeah, definitely. If you review the literature, you would see a lot of technique dealing with the CTS, the timing of putting the CTS, the timing of passing the suture, and everybody is going to defend his way or technique of dealing with this type of CTS. So I think it depends on the surgeon preference and the surgeon's experience. Would he pass the suture before having the CTS inside the eye, or after having the suture inside the eye? Would he put it before, or would he put it after? I think it depends on the surgeon experience and the case itself.
There is a question regarding the femto laser for the capsular rhexis.
I think in this case is difficult due to the tilt, unless I don't know. I don't believe that it can be done in my case. Maybe Dr. Saad's case it is possible, but not in my case.
So some they think, you know, the femto laser even would be better, you know, for subluxated lens, but unless you can see part of the anterior capsule, that you can do it. Even with the tilted lens, they can do the anterior capsulotomy with the femto laser. So even it will reduce any tension when you are doing the rhexis. But it depends on how much subluxation and how much of the anterior capsule you can see. But it can be done, you know, as a femto laser.
I remember a case I did during my fellowship with Dr. Asiri. It was subluxated lens. I used the iris hook to hook the lens capsule. Then there was like a radial extension. So to which, again, I will ask again, Doctor, although I asked him during the case, but for the benefit of the attendees, just to how safe we can use the iris hooks, as Dr. Also in the case of Dr. Muhanna, he did it just now, to hook the capsule, especially when you don't have really the capsular hook.
I think it's risky, you know, because I think Dr. Muhanna, maybe he has magic hands. So he didn't have any, with the 5 hooks, he did not have any extension. But it's really, in these cases, it would be much, much better to use the capsular, hooks rather than the iris hooks.
There are hints for this. If you have the capsule is very small, then it's better to have the hooks not to have just enough tension just to hold the lens, rather than just to pull the anterior capsule or capsular bag. And it's better to have a bigger capsular rhexis so that you will fix it better away from the center of phacoid multiplication.
So, Dr. Barry, just if there is no more question, we'll conclude with this question. It was also asked here in the question and answer area. When you really think that, no, I will not try to play with this subluxated lens, I will just open a large wound and just take it as an ICCE?
I think we answered this question. I mean, if you think that the procedure is going to be more difficult in your hands, in the surgeon's hands, or there aren't the available instruments available, CTS, CTR, and so forth, it might be at this point more wise to do a lensectomy and then to place a sclerosucciated lens. rather than doing all of these manipulations and causing more probably complications.
There is a question regarding the yak capsulotomy later. When to consider it, or
at least
this
6
is
months.
for all.
I think 6 months is usually the minimum time until you're sure that the eye is really quiet and the capsule has significantly attached to lessen the risk for macular edema and so forth.
Even I think if you have a CTR and maybe an early yak capsulotomy, you might have some extension. So it's better to have it later, so you have enough capsular fibrosis, so you don't have any extension if you do it early.
For capsulotomy, you can always have a smaller one. You don't have to wait 6 months, especially with capsular fibrosis or opacification usually happens in younger individuals. And with these patients, usually the healing is much faster. So capsule tension ring as well as the IOL haptics will be sealed by the 2 leaflets of the anterior and posterior capsule. So I think you can do it much earlier than 6 months, and do it centrally enough for them to improve their vision.
Isn't there any risk for macular edema?
I mean, 3 months, I think, is a reasonable time to start.
Okay. Would you have placed an air bubble if you didn't have any kinocort at the end of the procedure, at the end of Dr. Mohammad's procedure, to support to push the iris away and possible vitreous being invited to the anterior chamber?
I wouldn't put an air bubble because it might go back and it might do the opposite. It might push everything anteriorly. So I wouldn't put an air bubble here.
I think is a reasonable time to start. Would you place an air bubble if you didn't have any kinocort at the end of the procedure, at the end of Dr. Mohammad's procedure, to support to push the iris away and possible vitreous?
So I have here a question for my case. بس في صوت جاي introducing. Yeah. So here is a question. If you have a vitreous in the AC before surgery, what will be the plan? It depends on the amount of the vitreous. You can just push the vitreous back using a dispersive viscoelastic and just fixate the bag, as Dr. Ali mentioned, using the CTS, or you can do a limited anterior vitrectomy and then start fixating the bag. I don't know if any of the panelists have any other opinion. No.
No comment.
Nothing.
طيب. By the end of this webinar, I want to thank all of the participants and the presenters, Dr. Saad Al-Harbi and Dr. Mohammed Jandan, for their nice cases and initiative discussion. Also the panelists, Prof. Ali Rajhi, Dr. Abdullah Asiri, and Dr. Ma'an Al-Berri, for the nice, informative and interactive discussion of this case. I wish all of you a pleasant night and blessed prayers. And we are waiting to see you for our coming webinar that will be announced, inshallah, soon. So thank you all for your participation and attendance. Thank you.
Thank you, Dr. Mohammed Al-Shamrani, for organizing this, and thank you to both presenters and to the rest of the panelists. And I was really honored to have been invited.
Thank you for all, and thank you for the excellent cases and also for the organization. Thank you.
And a good management for the 2 cases also.
Yes.
نبيلكم الله يعطيك العافية.
بارك الله فيكم.
Yeah.
And thank you to the audience.
Good job.
For staying. We still have 105.
بالضبط كنت حقولها سبقتني مهند.
أنا اللي قلتها. شكرا.
شكرا جميعا، يعطيكم العافيه.
السلام
يا
عليكم.
أمان. ونحن على خير ان شاء الله.
نعم.
مع السلامة.